Dr. Chen, we are so humbly grateful that Dr. Chen is able to join us today. Dr. Christine Chen studied internal medicine in Vancouver and did her hematology residency in Hamilton. She then completed a transplant research fellowship at Princess Margaret and afterward joined the myeloma and related disease program there. She's also has a master's in education and takes an active role in medical education, including previously being the University of Toronto Hematology Training Program Director and the Myeloma Fellowship Director. She is now the Medical Director of the Autologous Stem Cell Transplant and Cell Therapy Programs at Princess Margaret and contributes hugely to research. However, most of us know Dr. Chen as an immensely knowledgeable, capable, caring, and kind myeloma doctor who is highly regarded by her patients and much appreciated by them. So since, as you can see, Dr. Chen has a tremendous amount on the go in her professional life in addition to her family, we are so honored and privileged that she is able to take the time to prepare a fabulous presentation, you'll see it, for us, and to join us here today to present it. With that in mind, would you please join me in giving Dr. Chen a most warm welcome.
So thank you very much. I hope this works. I'm really, really pleased to be here today. It's been a number of years since I've been invited to speak, and it's always a pleasure. And I can't see everyone online, but welcome as well there. So these are my disclosures, and so thank you very much for the invitation. I was asked before I get into updates in myeloma from this past year, David asked me also just to quickly run over how you can get on a clinical trial and a little bit about the research terminology, because when I go over the data, I will refer to some terms that if you're not familiar with might seem strange. So this is a slide, this first slide is just how the process we go through to get an idea in terms of a target or treatment for myeloma, how we get from that idea to a treatment into patients. And so our basic science colleagues start off with development in the lab, and they look to find targets or pathways that can be the focus of treatment. And then our translational research partners and colleagues then take it from the lab and they try to develop drugs or treatments that will be appropriate for that target. So for instance, Suzanne Trudel is one of our major translational researchers in our lab. And then from there on, once we've developed a treatment, then we go into clinical trials. And I'll talk a little bit on the next slide about the phases of trials, phase 1, 2, 3, which ultimately with phase 3 trials will compare to what we have as standard right now, and it'll throw that standard out and move on to a bigger and better treatment. And once that treatment then has passed the phase 3 level, then we're ready to try to move it into the market. And that requires regulatory approval, which in Canada means Health Canada approval. This is the equivalent of the Food and Drug Administration in the US. But and that's at a federal level. So you may all hear about Health Canada approvals, but then it takes about a year to a year and a half more to get through funding. And funding is provincial. So each province has their own way of funding drugs, and that's why you will sometimes see discrepancies between the provinces in what drugs are accessible. But our funding agency in Ontario is Ontario Health, previously referred to as Cancer Care Ontario. And then when approval and funding have come through, that's when we can finally get the treatment through to you. In the interim, there sometimes is a compassionate program where we can access drugs from the company for your use before funding is available. So it's all fairly complex, but we keep this in mind when we try to look at each patient to see where can we access drugs along any phase of the clinical trial trajectory. And this is just a bit of a background on what the phases of trials mean, phase 1, 2, and 3. Phase 1 is when we are just testing a small number of patients, and our goal is really to establish, to look at the side effects and then to find a right dose. So often we'll have dose levels. So we start at a very low dose, and then we slowly build up. We usually put 3 or 6 patients just on each dose level until we get to a point where patients develop side effects that we think are dose limiting, and then we stop escalating and we drop back a dose level. And that dose level is what we then take on to phase 2. And the focus of a phase 2 trial is to just see at the right dose, we now know it's safe, so does it even work? And that's the focus of phase 2. Phase 2 trials are often still quite small. Sometimes it's just 100 patients, but they can be bigger and even randomized, and I'll talk about that in a second. But ultimately, if we have a good signal that a drug is useful and works, then it moves on to phase 3. And phase 3 is a comparative trial where we have our standard treatment. Patients get put into one of 2 or 3 groups or even more. And the standard patients are treated with whatever we normally use now, but the experimental arm gets something new. And that way we can compare the results and really be sure that this is a treatment that will benefit our patients. And then if that is a positive, then the standard care is now thrown out and we move on to newer and better treatment that was tested in the experimental arm. So you guys may be involved in any trials that are phase 1, 2, or 3. There's even phase 4. After a drug is approved, we sometimes look further at bigger numbers of patients who are being treated in the community to evaluate for toxicities in larger numbers than was just tested in the phase 3 study. So I wanted to show you this slide of the determination trial. Sorry, the graphics are a bit off. Because I'll talk about this trial a little bit later. This is a study that was presented last year at a couple of meetings. The goal of me showing you this is the study design and terminology I can apply to this study. So this is a trial that was performed by Dana-Farber and compares what is considered a standard non-transplant arm, so arm A, which is with Revlimid or lenalidomide, Velcade, or also known as bortezomib, and dexamethasone. So this is a combo we call RVD, and is a widely used combo in the US and more and more in Canada. And it compared, that was the standard arm, and then it compared to arm B, which was the same regimen, but you add on transplant. So this was a study trying to determine whether transplant is really needed when we have all these great combinations with highly active drugs. And so this slide, I'm just trying to show you what these mean. So to get on the trial, patients were randomly put in either group. So randomly means it's just arbitrary. Usually it's a computer-generated randomization, which is even more random than flipping a coin. And so you don't know which arm you're going to get into is what this means. And the goal of randomization is to make sure that we're not biased. So if you got to choose what treatment you wanted, perhaps the more motivated, younger patients who are fitter might want to go for the transplant arm, and then the two groups would not be the same. The two groups, one I mentioned is called control group, the other is called the experimental arm. The treatment arms usually have to be very well defined in terms of what the regimen is. Cycle length will vary by study. And then there are primary study endpoints. And in this study, the endpoint was PFS, which is progression-free survival. So what does that mean? Well, progression-free survival is how long patients live without progressing with myeloma. So you'll see us using this endpoint a lot as an alternative to overall survival. I mean, ultimately, we want to make sure a treatment lets you live longer. But if every trial used overall survival as the endpoint, and patients are living decades now, we would have to, one trial wouldn't finish for my entire career. So we had to find some endpoint that's earlier. And so progression-free survival is what we call a surrogate for overall survival. And this is the curves that got generated from that determination trial, with the red curve at the top demonstrating the progression-free survival curve from the transplant arm. And so what it means is on the x-axis, so the horizontal line, it's months, time from when you got randomized on the study. And the y-axis, which is vertical, is just the percentage of patients. So you can see it starts at 1, which is 100% of patients. And then as patients progress with their myeloma, they drop down on the curve. And so if there are a lot of people who are progressing, the curve drops faster. And so you can see that the curve drops faster with the RVD alone arm, meaning it's inferior, and that's our primary endpoint. So I'll come back to that later, but that was really just to show you a bit about our endpoints and some of the curves that you're going to see if you look in the literature. So how do you get on a trial? Well, ask your myeloma team. We're always trying to offer trials at every phase of disease. Eligibility criteria can be very picky, so don't feel bad if you don't fit a trial. They want to be really sure that you fit what they're trying to test. We screen, we have one person in our trials group who just screens everyone to see if they fit. Your doctor and the study coordinator will provide you with an overview of the study as well as consent forms. When we consent you, which is really just giving you more details about the study and having you sign that you want to participate, bring a friend or family, take time to read the consent at home, ask lots of questions. We never accept consent on the same day we present it to you because we want you to go home and think about it. Talk to your family doctor, talk to your friends and family, talk to your oncologist. And questions to ask are details about the treatment. Are these pills? Or are they injections? How long are the injections? How long will the visits be? How frequent? How long do you stay on treatment? Most treatments for myeloma you stay on indefinitely now. But we're moving more and more into treatments that actually stop at a finite time period. Will you always get the treatment or is it randomized? So we talked about that. Will you know what treatment you will get, or is it blinded? Blinded means that you won't know which treatment you're on. If it's a pill, they may give you a placebo or at least not tell you what there's often a combination of treatments. Maybe one of them will be a placebo. So you want to ask about that. What extra tests are needed? What are common and serious side effects? And are there extra costs? A lot of the time, clinical trials will cover the routine costs of you traveling or staying in a hotel or something to be close to the hospital. Okay, so that's my short run-through of clinical trials, and now I'm going to go over what's new in myeloma. I actually think, Dave, this is a slightly older version of the talk because I expanded my topic to just be what's new in myeloma from 2022. Beyond just ASH. ASH, as you know, many of you know, is the American Society of Hematology meeting that's held in December every year, and it's our pivotal meeting where often breakthrough trials are presented. So I will focus on a lot of data from ASH, but also there were many other meetings where there was really useful info in myeloma that was released. So I'm going to talk about minimal residual disease testing, also referred to as MRD. Why is it important? And then I'll talk about frontline treatment and treatment for relapse. So what is MRD? Well, this is the most important post-treatment predictor of outcome. So you guys know with your myeloma, you either have protein and M protein in your blood, that we measure as a tumor marker, or you have free light chains, or you have something, protein in your urine. Those are markers of disease. When those levels go low, we use them as response predictors. If you go into a complete remission, then your myeloma protein goes to 0, your free light chains normalize, and if we were to repeat a bone marrow, we wouldn't be able to see any of the myeloma cells left. But we still know you have myeloma there. We're currently not able to cure myeloma. So even though we can't see the myeloma in your bone marrow with the naked eye, we know it's still there. So MRD testing takes us into a much more sensitive level of having a small amount of disease. So at a molecular level, we can measure down to 1 myeloma cell amongst 100,000 cells. And that's way too sensitive for you to see just with your naked eye. And so that level is what we call 10 to the minus 5, and you'll hear us referring to 10 to the minus 5, 10 to the minus 6. These are just differing levels of molecular disease. And why is that important? Because if you get into a very, very deep level of MRD negativity, where there's just a little bit of residual disease, it will take you much longer for those little number of cells to grow to a level where they're going to cause clinical symptoms for you. And so the less disease you have left at a molecular level, the longer your response will be to your current treatment. So it is a very important measure that we are starting to do quite routinely at Princess Margaret. Unfortunately, it's currently only tested from bone marrow samples, although as I mentioned, my translational colleague, Dr. Trudell, is looking at testing it in the blood with a measure called cell-free DNA. So that's MRD. I wanted to spend some time on that because you'll hear me talk about that as an endpoint in some of the trials for this talk. So let's move on to frontline therapy. And I put this slide up because a lot of, you may hear about patients being treated with something and then not maybe going on lenalidomide maintenance because they want to save the maintenance, the lenalidomide for later. We strongly feel at Princess Margaret that we should treat you with the best treatment up front. So basically put your best foot forward, because what we unfortunately see is that a number of patients, and so this is a study that showed that 21% of patients who finished their first treatment actually didn't go on to a second treatment. And perhaps that's because they were older, they passed away for unrelated reasons, but they may also have passed because their myeloma was not well controlled, or they had more complications from disease or treatment. And so we don't want to give you substandard front treatment and not give you the opportunity for the best therapy. So that's our motto, and that is what you're going to see as we talk about frontline treatment in those who are transplant eligible, because there are a lot of discussions these days about how hard we should or how intensive we should make frontline treatment. So I'm going to talk about the transplant patients first. So this is a bit of an old version. I had another slide just saying that that the first treatment decision we make when we meet you for the first time is whether you're eligible for transplant or not. And a lot of the eligibility is based on how fit you are, whether you have a lot of health, other health issues. We don't have a very sharp age delineation, although obviously the older you are, the more other health issues you tend to have. So somewhere, we rarely transplant people significantly over age 74 or 75, but we will if you're a very fit 76-year-old. So what are we doing? Well, on the right, you can see that in patients who are fit, this is an image that's not from our center, so it says 71, but we don't have an age cutoff. We usually start with induction therapy, which is your first treatment. And the traditional treatment is with something called Cybor-D. Many of you will be familiar with it. It's cyclophosphamide, BOR is bortezomib or Velcade, and then D is dexamethasone. Transplant, and then standard lenalidomide-based maintenance. And on the left, is a bunch of survival curves from an analysis from one of our colleagues from Hamilton, who showed that from 2007 on, in incremental 2-year periods, we've done better and better. So these are all the survival curves I showed you before. So the higher the curve, the better, and the longer people are living. And so you can see that the worst years was back in 2007, and we've been progressively getting better. So we've certainly made advances in the last 20 years, better induction, and I'll talk next about what else can we do to enhance the induction. I'll also talk about the optimal duration of lenalidomide maintenance. This was evaluated at ASH this year. And then we'll talk about high-risk patients, because unfortunately, patients who have bad genetic tests or various other ways of identifying high risk still don't do that well with this approach that I've listed here, with just Cybor-D transplant and lenalidomide maintenance. So we need to find better therapy for those patients. And this is just the same thing showing that the CMRG with the Canadian Myeloma Research Group also was reviewed our data. This was by Julie Coté, who's one of our myeloma fellows from a couple of years ago, that we are now able to achieve survivals of over 10 years with transplants. So we've really made strides over the last 15, 20 years. So I already showed you this study design from the determination trial. So this is a study that looked at transplant but stepped up the induction to RVD, because as you know, we usually use Cybor-D, and RVD was the backbone here. And I just wanted to show this again to reiterate that on this study using RVD plus transplant, about half of patients were able to get into that very, very deep level of response, MRD negativity. So that's really impressive to achieve that. This is far more than we can achieve with Cybor-D with transplant. And I showed you this PFS, or progression-free survival curve, previously. And just to reiterate that the RVD plus transplant arm was much better than just RVD. So this study shows us that transplant is still valuable, even in the era of novel combination therapies. But this study, I should note, didn't show in the end that patients who got transplanted actually lived longer, because the study has been going on for a long time, and they came up to, I think, 6 years of follow-up recently, and they found that patients live the same whether they got transplant up front. So some people said, well, does that mean we can delay transplant? Maybe we don't need to do transplant up at the beginning. But we strongly feel still that there is advantage to that many patients, unfortunately, on the determination trial didn't get to a second transplant. It leaves still some room for personalization of whether you want your transplant up front or if you want to just wait until you relapse the second time and have your transplant. And so you'll see across the globe that there are various approaches. Can we step up that induction therapy even more? So we think RVD is better than Cybor-D. And if you're newly diagnosed myeloma, you'll see us trying more and more to get RVD routinely. It's not fully funded yet in Canada, so that's a bit of a battle. But this Griffin trial, which you may have heard about in recent years, adds on daratumumab to RVD. So daratumumab, as you may or may not know, this is a slightly old version. I had a slide on daratumumab, but it's been around for a good 5 years now. It's a antibody to CD38, which is a marker on myeloma cells. And so it's our first antibody for myeloma and has been really critical in changing the outcomes of lots of these treatments. And so the Griffin trial was presented last year at one of the meetings and compares just standard VRD, which is the same as RVD in the determination trial, which we think is better than CyBorD, and then, but added DARA all through, either in induction and then after transplant, and then DARA was added to lenalidomide in maintenance. And suffice it to say, the daratumumab arm led to significantly improved progression-free survival, so length of time that your disease stayed stable, over the RVD alone. So this, I think, is practice changing, and we are now hoping that daratumumab can be added to RVD for transplant candidates. Again, this is early, so we have to wait for approval. And this just shows you that by using the DARA plus RVD at induction, after transplant, and after maintenance, after 2 years, we're now able to inch up that MRD negative rate to 64%. If you recall, in the determination with just RVD transplant, we were getting around 50%. So you can see we're getting better and better. Deeper responses translates into longer progression-free survival, which is what we're seeing here. So much better than just with RVD with no DARA. This study also looked at quality of life, because anytime you add on more drugs, we always worry that there are too many side effects, but the quality of life was actually improved with DARA RVD, probably because it's better for the myeloma, so myeloma-related symptoms are better, and that sort of trumps side effects. So if we move on to maintenance, because there was also interest in maintenance last year in studies. Many of you are probably on lenalidomide maintenance, and the initial trials of lenalidomide used maintenance indefinitely. As long as it was keeping the myeloma quiet, you just stay on it. But some patients struggle with it. They can have low counts, they can have problems with fatigue or diarrhea. And so it can be a challenge staying on for many years. So this was a study from the UK that was presented at ASH that looked at different time points of lenalidomide maintenance in a very large trial of over 1,200 patients. And they looked at 2 years, 3 years, 4, 5 years. And what they found is that the best outcomes with maintenance appear if you can continue for at least 3 years, probably closer to 3.5 years. And why that's important is because if you're struggling to stay on the lenalidomide because of side effects, then it may help us feel more comfortable that if you've hit the 3-year mark, we could probably stop. I'm not sure I would do this for everybody, but it allows us to start moving towards personalizing these bits and pieces of treatment to individuals. So if you can't tolerate it, let's get you to 3 years. If someone else is doing well, let's keep you going. You'll hear also that if you have high-risk disease, it's ever more important to be on continuous treatment to keep your myeloma quiet. So we are getting to the point where even though we have sort of a standard approach to treatment, we're personalizing it to fit individuals. So high-risk disease, I'm sure all of you have had some of the traditional FISH genetic markers performed. I'm not going to talk much about them, but the first 2 significant ones we tested for was, you'll hear translocation 414. This is just when 2 genes are moved around, so they're side by side, and 17p deletion, which is part of chromosome 17 is gone. And those are the 414 is seen in about 20% of patients at diagnosis, 17p 5 to 10%. And these are two of our strongest markers genetically for a poor outcome. And you can see here that survival is much shorter if you have 17p deletion. And so we are always trying to find out the best treatment for patients who have high-risk disease because, as I mentioned before, a standard single transplant and lenalidomide maintenance is not very effective. So better and better ways of determining risk have been a focus of recent years of research. In particular, we now know that we can do something called gene expression profiling, where we test a whole bunch of genes, and in this case it's 92 genes, and we look to see what pattern you fit, because some genes are overexpressed, like we see a lot of them, the genes being stronger, and some genes are underexpressed. And patients who don't do so well will have a particular gene expression profile or signature. And so we now know about 20% of patients at diagnosis will have this high-risk signature. The reason why I particularly mention this is because we are now rolling this out at Princess Margaret and performing it in all frontline newly diagnosed patients to try to better find the bad players who need to have treatment stepped up. Oh, sure.
There was someone that wanted to know if patients can stay on lenalidomide forever, like indefinitely.
Yes, in fact, that's how the original trials were set, that patients stayed on indefinitely until it didn't work anymore, which is evidence of the myeloma growing. There are side effects to lenalidomide maintenance. As I mentioned, some of the common ones are diarrhea and low counts, predisposition to infections. And one of the more concerning risks we have is the lenalidomide can damage some of the cells and cause increased risk of second cancers, particularly blood cancers like leukemia or something we call MDS. So there is a lot of interest in trying to identify patients who can stop, right? So hence the study I just presented. If you can stop at 3 years, that may decrease that risk of second cancers. Most of the cancers that develop are more like skin cancers that can kind of be dealt with quite easily, but even so, you don't need another cancer to worry about. So yes, you can give it indefinitely, and that's how we gave lenalidomide. We still do give it that way because it seems to control the myeloma better in that way, but maybe not in all. In some patients, maybe you just need 3 years. So I'm going to go back to the high risk. So this is the way that the UK group, presented by Martin Kaiser at ASH, looks at risk, because not all high risk is the same for every patient. Some people have high risk because they have bad FISH genetics. Some people have a bad gene expression profile, which is the risk, the SKY92. Some people just have really bad clinical disease, and one bad player is when you have your myeloma cells floating around in the bloodstream, because myeloma cells like to adhere to the bone marrow. When they come out in the bloodstream, we call that plasma cell leukemia. That usually means your disease is more aggressive. So these guys in the UK slot you in anywhere. If you have high-risk genetics or gene expression profile, if you've got plasma cell leukemia, whichever one of these, they consider you high risk and will treat you as such. So it's the way that we're moving to do sort of these combined risk scores. But it's all fine and dandy to identify high-risk patients, but what are we going to do with them? And what we're seeing more and more is the use of intensive multiple drug combinations that include an antibody like DARA. And so this is the MASTER trial that was presented at ASH, and shows that the DARA plus K, which is carfilzomib, R is lenalidomide, and D is dex, is a highly effective combination, and no doubt expensive as well. It's very, like we can achieve MRD negativity in 80%. Remember I said with DARA-RVD we were getting into 60%, with RVD more like 50%. So we're getting better and better at getting people into high risk. But unfortunately, this study allowed people to stop treatment if they achieved 2 MRD negative tests in a row. And what they found is the high-risk patients still relapse faster when they stop. So the caveat to how long you can be on lenalidomide, maybe some can stop at 3 years. In high-risk patients, we strongly feel you need to continue indefinitely, and we also encourage double maintenance with lenalidomide and another drug. And this is basically what I list here is our high-risk treatment policy, where we use stepped-up induction, we do 2 transplants, and then we maintain with 2 drugs. So let's move on to those patients who may be older or have health problems and they're not eligible for transplant. And the big news that emerged last year was the MAIA study, the DRD, daratumumab, lenalidomide, and dex, was finally funded in Ontario. So many of you may be taking part in this regimen. This was the MAIA study that compared DRD to just RD, so lenalidomide and dex, which is one of our treatment options from the last few years. And what it showed was a significant improvement by just adding the daratumumab. And we were starting to see patients lasting 5 years or more in their response. So this is getting close to what we can achieve with transplant. And remember, these patients on this study were older and not so fit. So that's pretty impressive. And it now allows us the opportunity to give patients who are sort of in that range, somewhere in the 70s, maybe not so fit, but not unfit enough to say no transplant. But we now can give you kind of some options, transplant, no transplant, with very good outcomes both ways. However, DARA-RD does have its drawbacks. It's originally an IV, but as many of you know, we now have the sub-Q formulation, so it's a lot easier. Instead of a long IV infusion, it's now a much shorter injection into the skin. There are frequent visits, at least initially. There's a long-term commitment, because this treatment, unlike transplant, continues long-term until it doesn't work anymore, until the myeloma is growing. It's quite expensive, significantly more than transplant, and there are toxicities. So I apologize, this is not a very clear slide, but the green, all the side effects are kind of listed there on the left, and the green bars represent the DRD patients, and the gray bars are those who just got RD. And just visually, you can see the green bars are longer, so there's more patients with side effects with the addition of DARA. And that's no surprise. I mean, we added a 3rd drug, so they will get side effects. One of the main things we worry about is infections when we add on an antibody. So when you're starting off a new treatment with something like DARA-RD, you get an antiviral drug, you get an antibiotic for the first 3 months, and you get a second antibiotic to prevent a certain kind of pneumonia. So there's lots of prophylaxis and close monitoring. At ASH, we also saw, for patients who are not transplant eligible, an interest in trying to get rid of the dexamethasone. So any of you guys have all been on dex. Can't imagine anyone liking it unless you want to clean your house at 2 in the morning. So this study was looked at, can we replace, instead of RD, the lenalidomide plus dex, which we were using pretty routinely before, in older patients, can we use lenalidomide plus daratumumab instead, no dex? And this study showed that with the DR arm, that we could get patients into deeper responses, and there was not significantly more side effects or increase in infections, which we always worry about with DARA. So this is a really interesting study because they picked out people from the get-go who were frail. And so there's a lot of impetus right now to do frailty assessments in patients and use it to help decide who should get transplant, who should get more intensive therapy, who should dose reduce, who might be able to do something without DEX. This is one of many studies that is going to be looking at trying to optimize treatment for those who are a bit more frail. Anyways, so I'm going to move into relapse and refractory myeloma now. And we have largely moved in this setting to a personalized approach to managing relapse. We look at all the disease-related features, like whether you have low blood counts, whether you have some complications like kidney dysfunction, what your age is, and then therapy-related factors like are you eligible for transplant, what kind of side effects the drugs have that may be problematic for you. But what we've moved to also recognizing is that the prior therapy you've had, how deeply you've responded, how long you've responded, and also whether you're on the treatment at the time that you progress is really a critical factor that we take into account when choosing next lines of treatment. And as a result, you're going to see us a lot of the time talk about whether you're refractory to lenalidomide or Revlimid, or whether you're not on Revlimid when you progress, because it really does change the options. And this is only supposed to be an hour talk, and I really can't go into a lot of details about all the options, but all to say that we look at all the features I showed on the previous slides, and then there's more and more patients who are progressing on Revlimid that we need to find non-Revlimid based treatments for. So you'll see a lot of the times we use K, which is carfilzomib, which is kind of a bigger, better version of Velcade or bortezomib, pomalidomide, which is kind of a bigger, better version of Revlimid. And then there'll even be drugs like selinexor and venetoclax that we reserve for people who have specific features of disease or genetics. So that's all I'm going to say about regular treatments, standard of care treatments, because what I'd like to do is talk a little bit more about the people, essentially everyone eventually will have what we call triple exposed disease. So you'll have had exposure to the three major classes of drugs. One is the IMiDs, immunomodulatory drugs like Revlimid and pomalidomide, the proteasome inhibitors, which is like bortezomib or Velcade and carfilzomib, and then the third class of drugs is antibodies. So if you've had all those three, then usually the next step is we move you towards immune-based therapies. And there are three big categories. On the left, you see what we call antibody drug conjugates. So you have an antibody, it zooms in, targets the cancer cell, and it's got attached to it a toxin, and that toxin then kills the cancer cell. And so belantamab is our main antibody drug conjugate. We are testing others in clinical trials now. I'm not going to talk much about belantamab, except that maybe some of you are on it and are already familiar. But I am going to talk more about the other two big groups, because there's a lot of data at ASH and other meetings about these two. One is CAR T-cell therapy, and the other is bispecific T-cell engagers. So CAR T-cell therapy, CAR refers to chimeric antigen receptor. Chimeric kind of refers to having two receptors, and in fact, this image on the left is what a CAR looks like. So at the top is your tumor cell, and the lower part is the T cell. T cells are cells in your blood that are like little soldiers that can fight cancer. And so what we do is genetically engineer the T cells so they have this CAR sticking out of them. The part outside of the T cell can recognize the tumor cell and bind to it. And then when it binds, it sends a signal back into the T cell and activates it. And when the T cell activates, it turns into that soldier and can kill cancer cells. It can also make more T cells that will also continue to kill cells. And the advantage here is it's one infusion of cells that can, these CAR T cells can potentially live in your body for months, if not even years, continuing to keep the myeloma under control. The problem is that when the T cells activate, they release a lot of substances we refer to as cytokines, and those can wreak havoc with you, cause fever, drop your blood pressure, cause all sorts of other organ dysfunction. There is a risk of neurologic disease also, because the CAR T cells can go into the brain and the fluid around the brain. And because this is major immune-based therapy, the immune system is weak and you're very prone to infections. So this is just a little graphic about cytokine release syndrome, which I already mentioned can cause all sorts of side effects. And mostly when it occurs, patients usually start off with a fever. We will give treatment which is inhibitors to these cytokines. So IL-6 is one of the main cytokines, and we have an IL-6 inhibitor called tocilizumab. You may have heard of this drug because we also use it to treat the cytokines that are released when you get bad COVID. But there are other treatments like anakinra and steroids as well. CAR T cell therapy is very complex and intense. You start off, you have to collect the T cells from patients, much like when you're doing a transplant and we collect your stem cells. We put you on the same machine and collect T cells instead, and then we send those frozen, well, sometimes they're frozen, sometimes they're fresh, we send them out of the country where they are then manufactured to genetically engineered to express the CAR antigen, and then they are expanded, so there's lots of CAR T cells, and then they're frozen and sent back to us. And then we infuse them into patients, much like we did with a transplant, where we thaw them out and we just give them back after we give some chemo to create a bit of immune space in your body. So you can imagine, much like with transplant, it takes a village to complete a CAR T cell therapy for any one patient. But what we are seeing is really impressive results. We are mostly doing CAR T right now for lymphoma, where it potentially is curative. In myeloma, we're not quite there in terms of cure, but we are getting very excellent results. So cilta-cel is a CAR T targeting a myeloma antigen called BCMA. This is an antigen, this is a marker on myeloma cells, and over 90% can achieve MRD negativity. Remember I was talking about MRD negativity, 50% with RVD transplant, even higher with more complex treatment. Well, with cilta-cel, we can get over 90% MRD negativity. And these are heavily, heavily pretreated patients who have had 5, 6 previous therapies and failed them, and are normally really difficult to treat. So cilta-cel was just Health Canada approved in March, yay. So we anticipate, again, remember I told you that after approval, still takes a good year and a half before funding comes through. And these are very resource intensive and expensive treatments, so I think the funding may take a while to come through. And this is just to show you that the cilta-cel trial that led to approval was performed in really heavily pre-treated patients who have had 5 or 6 lines of therapy or more. But we're now seeing the CAR T move earlier and earlier. So at ASH this past year, we saw some data from patients who were only in their 2nd line of treatment but relapsed early. We know those patients tend to be bad players. If you don't get much kick out of your first treatment, like number of years, then we know that you've probably got some resistant cells. So these patients were picked out to go straight to CAR T in their 2nd line. And you can see everyone responded. The numbers are small though. Everyone responded, and we're now hoping that those responses will last. The other common, yep, sorry.
Quick question. So if MRD is, I guess, a higher response than SRC, then why sometimes SRC higher than or lower than MRD?
Are you saying SCR, stringent CR? Is that what you're saying? Yeah. So CR is all based on whether you can see a protein or cells left in your bone marrow. The MRD is always more sensitive than that. So it's at a deeper level of response than complete remission. S means stringent. SCR, stringent CR, means you are a little bit more in depth than just a plain old complete remission. But MRD essentially is a deeper response than that.
Previous slide said 90% MRD, but then SRC was 84%.
Yes, I'm sorry, like this is at different time points, right? So I'm just showing you the bar graph, but so you can still have, and this gets a little complicated, that you can have a complete remission or not be in a complete remission because you still have a little bit of protein left over. Because the protein floats around in your blood for a while before it actually goes away. It doesn't mean that the cells aren't gone though. So MRD testing is when in the bone marrow, we look to see there. So sometimes you will see MRD, but you still, MRD negative, but we'll still see proteins floating around in the blood, so they don't quite match. But also the bar graph is, I'm just showing you sort of the overall responses here, but what we're seeing is MRD testing. This is the cohort 2 with early relapse. I didn't show you the MRD testing here. That was on the previous trial that had longer follow-up, so we can see MRD might take 6 months to achieve. This is just overall responses from this study that was presented. It's very early. I think their follow-up is only like 6 months so far. Okay, so don't get the two trials kind of mixed up. I'm showing a whole bunch of studies with different data. Just because it's cilta-cel doesn't mean the same results happen in each different population.
And before you move on to the advisors, is CAR T, there's a question from Zimmer, is CAR T an option for high-risk myeloma patients?
Yeah, so that's actually a little bit of what I was showing on the previous slide, that one way of identifying high risk is that you relapse early. So we're doing tests on, that was a study looking at cilta-cel in that category of high risk. But there are other trials that are looking at identifying high risk in different ways, like I tried to show you earlier, and introducing CAR T earlier. Rather than waiting until you've had 3 or 4 lines of treatment and just giving it to people who have had lots of therapy and don't have other things left, we are trying to move it earlier and earlier. The main caveat is usually if you move treatments earlier, they are more effective, right? And maybe even curative down the road. Are there any other questions? So I'm happy to answer more questions at the end, but let's move to the bispecifics. There's lots of interest in bispecific T-cell agents because this is a little bit more accessible than CAR T. So we're still taking advantage of activating the T-cells so they can kill cancer cells, but it's a drug instead of modifying the cells themselves to activate. We actually just have a drug that bridges between the T cells and the cancer cells. And so because it's a drug, you have to keep administering it. It's not something you just do one infusion of cells and they live in you forever. You have to continue to administer, and right now they are still given until progression. But the advantages over CAR T is you can start much more rapidly. Remember, for CAR T, we have to collect cells from you, send the cells off to be manufactured, and that takes 4 to 6 weeks. And some patients are progressing pretty rapidly during this time, and they can't wait that long. Because this is a drug, and it's not cells that need to be collected or engineered, it's a drug, so you can just start right away. It's a drug also that has only a limited period it's going to circulate in your system. So unlike cells that can live in you for a long time and continue to cause side effects, the side effects of these bispecifics will only be as long as the drug's floating around. Potentially, these treatments can be given in the community. You can't do CAR T outside right now. It's too intensive, requires too much expertise, and there's too many resources needed. Sorry, question? I'm going to get to that. I'm just introducing it on this page, only because there are a ton of them, okay? Here's a whole list. I'm not going to go over them all, but these were all presented in some way in the past year. But the main one is teclistamab, because that's the first one to market. FDA approved it in October 2022. We anticipate Health Canada approval sometime in the fall, okay, August, September. And of course, then it'll take some time to get to market. And this one targets BCMA, which is on myeloma cells. And what's important is that a lot of like cilta-cel is a CAR T that targets BCMA. And the problem is that often once you've had one BCMA targeted treatment, you're not allowed to get another BCMA targeted treatment, even if it's a bispecific and not the same kind of drug. So it's important to have other kinds of bispecifics that target other spots. And I think the key is here, we think that if you've already targeted a BCMA, sometimes that BCMA target will no longer be very active on the surface of the cells and things. So that's why we want to maybe try a different target for the next treatment. So it's really important that we also have these other ones, talquetamab and cevostamab, that are targeting other surface markers because that will be important to use next time. And the reason why I wanted to call out teclistamab is that there was a lot of data presented on the efficacy of teclistamab and this Majestic 1 trial, which was basically the first, it's a phase 1-2 trial, so it was just trying to ensure that it's safe and had some efficacy, has read out already and very encouraging results. The key about these bispecifics, and you might hear us sometimes referring to them as BiTEs, I think it's kind of just the short term, but these bispecifics do cause the same side effects like cytokine release that CAR T does, and so often we'll do a small test dose first to try to get the cytokine release we get the patient accustomed to it, and then we'll move up to a higher dose after that. And the first test dose, or some of the bispecifics use 2 test doses, that part needs hospitalization, and we watch closely for all the side effects we normally watch for with CAR T. So that's a little bit onerous and maybe a bit difficult when it gets rolled out for the community to administer. And so I only wanted to show this because it shows that a good number of patients respond. We can get 81% MRD negativity over time. And that on the right is just each patient is in a bar going across, and you can see that we are now finally starting to see that responses can last for a year and a half or so. Most of the studies prior to this were too short in duration to know. So this is really encouraging, especially since these are patients with really, really heavily pretreated disease. And as we move it earlier and earlier, we'll be able to hopefully see longer response durations. I already talked about CRS, cytokine release syndrome, is a major risk. And we learned at ASH this year a little bit better about how to manage patients with their side effects. And when this is a study that actually was presented by Suzanne Trudel from our group, it was a different bispecific than teclistamab, but the concept is the same, that we gave tocilizumab on the same day as the first test dose, and essentially showed that their rate of CRS was significantly dropped. So we're learning a lot about how to manage these patients, and ultimately we'll perhaps be able to eliminate that initial admission period. Another big risk with bispecifics, though, is infection. So because we're targeting the myeloma cell, and myeloma cells make antibodies, and many of them are good antibodies that help fight infection, we see everyone drop their antibody levels. An antibody, another term for that is immunoglobulin. And so patients are prone to all sorts of infections, and we're starting to see that the risk of infections doesn't stop with time, and that it continues to accumulate the longer that you're on. So we are now starting to more routinely give people antibody infusions, either monthly through your IV or every week. You can administer it yourself into the skin. And because the risk of infections doesn't really stop as long as you're on the treatment, this was a really interesting study at ASH because it took, again, small numbers, but there are 15 patients who had to stop the bispecific because of one reason or another, mostly it was all due to some kind of side effect. And what they showed was that at least, we always think these drugs have to be given forever, but when they stopped, their myeloma stayed quiet for at least 6 months and longer, we're seeing with some patients. I've had one of my patients stay stable for over a year and a half. So it's possible with these treatments we can stop and then minimize the risk of them having all these infections while they're on active therapy. And it's always nice for patients to be able to have a drug holiday. So this is my last slide. What's new in myeloma? Well, MRD negativity is important as an endpoint. In the front line, patients who are eligible for transplant, you're going to see us using more and more intensive combinations that can lead to deeper responses. For the transplant ineligible patients, DRD is our go-to regimen now, highly effective and now routinely available, and so effective that we may talk to patients who previously we would have transplanted that we might want to give them the option of doing DRD instead. And for relapse disease, sequencing, which is like knowing which order of which treatment to use next, is always tricky. But for those patients, I mean, pretty much everyone will eventually fail all three types of drugs we use, and we're very excited in moving more towards these bispecifics and CAR T. But we still have a lot to learn. So thank you very much for your attention, and I'm happy to take questions now.
When you're on DRD as a maintenance regime, will you, as long as that system is working, you'll stay on acyclovir and Cetera as well?
Yes. We do, as I mentioned, when you're just starting that, we'll put people on levofloxacin or some kind of other antibiotic for the first 3 months just to prevent routine bacterial infections, but just for the first 3 months. And then after that, just those two agents. Yeah. Oh, I'm sorry. I'm supposed to repeat the question. Sorry. I'm seeing David looking at me with, you forgot my instructions. Yeah, he was saying when you're on DRD and you're kind of more in the maintenance period, what preventive medications you take, and it's largely acyclovir or valacyclovir to prevent shingles, and then Cetera or something alternative to prevent a specific kind of pneumonia called PJP.
And that's only for DRD, not DVD?
No, we also use it in DVD. Every regimen, you look at the drugs and you decide what they're prone to causing, and we decide what's the most appropriate prophylaxis. DVD, DRD, really similar, right? And the V is even more concerning for risk of shingles, so we really do want to keep going with the acyclovir or valacyclovir. I should say that for DRD, sometimes if patients have been on a long time, we do drop the acyclovir because it's not as strong a risk factor for shingles as, say, the Velcade.
She has reduced the Cetera to Monday, Wednesday, Friday, just once.
Yes. Yeah, so there are 15 different dosing schedules for Cetera. I know one of my colleagues, Dr. Reese, liked to give it on Saturdays and Sundays only. I did on Monday, Wednesday, Friday, twice a day. There's like a whole bunch of different ways. So we don't really know what is the best for any one individual, but probably if you've been fine for a while, we can probably drop back a bit.
Do you recommend getting the shingles vaccine?
Absolutely, yes. We now have it's now Shingrix, very effective shingles vaccine that's not live. Like we used to have an old vaccine that was a live vaccine, so they gave you a little bit of the virus, and we always ask patients to avoid that because your immune system is weak. But the Shingrix is highly effective. It doesn't completely rule out your risk of getting shingles if you're particularly on like Velcade. So we still encourage, even though you've had Shingrix, to get some kind of preventive acyclovir or valacyclovir when you're on one of these drugs that's really problematic.
And I would get that after transplant.
Yeah, after transplant, your immune system is weaker, at least for the first year, if not more. And so our policy is to have everybody, even if you've had Shingrix before, get acyclovir or valacyclovir for a year, minimum. And then, of course, after transplant, we usually encourage people to get revaccinated. Even if you got Shingrix like a few years ago, we think some patients will lose their immunity. So, you could theoretically say not everyone will, but I think from our purposes, it's safer to just recommend that everyone gets revaccinated.
Sorry, do you take the acyclovir and the Shingrix at the same time?
Well, we recommend that you, as I said, if you had Shingrix before, but you're going on a treatment where we think your risk is higher, the Shingrix is not 100%. No vaccine will prevent anything 100%. So if you're on a drug, particularly like Velcade, that increases your risk of shingles, even if you've had Shingrix, you should be on prophylactic acyclovir or valacyclovir.
But should they take the Shingrix while taking acyclovir?
Well, if you're post-transplant, you're on acyclovir or valacyclovir, you don't start your vaccinations again till 3 months out. So yeah, when you're on your acyclovir, you're then going to get your Shingrix again sometime 3 or 6 months later. You'll be on both. I mean, the Shingrix is just 2 injections and then you're done, right? But yeah, you can get them simultaneously. You can get any vaccines while you're on these treatments. The concern is drugs like daratumumab and steroids, dexamethasone, really decrease your ability to mount an antibody response to vaccines, and that's why you'll sometimes, we'll try to hold those or get you to avoid them around the times you're getting like COVID vaccines, just to try to enhance your likelihood that you'll mount an antibody response properly. Yeah. Oh, sorry. Sorry.
A couple of Zoom questions. Is it clinical practice at Princess Margaret to take some patients off lenalidomide after 3 years? Or are there indicators that would determine when that would be done?
So at Princess Margaret, it has not been our routine to stop after 3 years unless patients are really having a hard time tolerating it. I mean, if you can't tolerate it, our goal is quality of life. So we're not going to force you to take something that makes you miserable. Or if your blood counts are too low, some people have low neutrophils or platelets and we just can't keep up the Revlimid. So we will stop if need be. It's this trial that was just presented at ASH in December, which would looked at the 2, 3, 4, 5 year mark of lenalidomide, was the one that first showed us maybe 3 years is enough. So it's not enough time yet for us to roll that out or decide that's strong enough data to stop. But it helps us feel better that if you're struggling with it, with side effects, and you're close to 3 years, that is actually, you've probably had a good length of time to get the most benefit.
Another one. In the States, it's often standard practice to collect enough stem cells for 3 transplants. Stem cells are harder to collect once DARA is implemented and or they're in the treatment journey. And stem cells can help bridge patients with low counts to a next therapy, perhaps potentially saving them. Why is it that Princess Margaret only allows enough for 2 high-risk patients that require 10?
Well, yeah. To be truthful, many centers in the States don't even collect for 2. So that's actually kind of not too routine at all to collect for 3. Many centers in Canada don't do 2 either. As we start to move into newer treatments that work in different ways, transplant has become a little less popular, particularly in the US. It is hard to undergo a transplant. You know, the recovery is much, can be challenging and can be slower than some of these immune-based therapies, even CAR T. So the longer you have myeloma, the less likely you're going to be able to tolerate it down the road. So we don't feel strongly that people will benefit from a 3rd transplant. 2 for sure, and so we collect cells for 2 if you're not elderly at the time of your first transplant. And if you're not high risk, we put that second sample away and save it for down the road. You will only benefit from a second transplant and potentially even a 3rd if you get a really good length of response duration to the first one. So if you only get 1 or 2 years out from your first transplant, you're probably only going to get about a year or less with a second, and we can do much better with other therapies, with immune therapies. So that's the decision making that happens when you relapse. We look, how well did you do with your prior treatment? How long did it last? How deep of a response did you get? And that helps us decide the next line. And so that's really critical when it comes to doing a second transplant. Very, very, very few people can achieve enough of a duration of response with a second one that we would routinely expect to do a 3rd. So we're not going to collect for 3 on 250 patients a year and only maybe use 1 down the road. So for us it's more, what's the likelihood that this will be a good treatment for you, like a 3rd transplant, and it's pretty slim. So.
Hi, Dr. Chen. Yes, a question on the Silta, is it Silta-cel?
Silta-cel, yeah.
Yes, so that was licensed in March this year, right?
Yes.
Yeah, so my question is about the phase, a few days ago, great. So my question is about the phase 3, and you mentioned that phase 3 is about comparing a new drug to a standard of care.
Yes.
In this particular case, was Silta-cel compared to what standard of care?
No, so it was...
Oh, because it's not a drug.
Well, no, it's like a drug, right? We call it a cellular drug. It's interesting. That's a good question, because over time, treatments that are really, really effective can get Health Canada approved at the phase 2 level. So the data that supported the Health Canada approval was a phase 2 trial. And the FDA routinely approves drugs on that level. Canada has often required you to have a phase 3 and prove it's better than another drug. But because these outcomes are so impressive, and it is actually hard to do a phase 3 with such complex treatment, the Health Canada approval was largely based on phase 2 data. Although there are phase 3 trials, we actually just finished accruing to a frontline phase 3 trial. Maybe some of you were approached about it, comparing standard non-transplant treatment to the chemo plus CAR T. And there are a bunch of other phase 3 trials in different settings that are underway. So we're going to see a lot more data, but the approval was actually not based on phase 3.
Okay.
That actually ties well with the question I have from viewers. Will there be a sort of standard of treatment for all myeloma patients, maybe in Ontario or across Canada, that becomes OHIP supported and that kind of thing?
Well, we have lots of treatments, but the thing is, and I hoped I relayed this, is that everybody's myeloma is different, right? And so what we're trying to do is have options so we can personalize it. We don't want to have to give you the same thing as your neighbor, because your myeloma is different from whoever's sitting beside you. So we're trying to assess risk better. We're trying to look at any health issues you have and avoid treatments that might make them worse. We're trying to look at your age and frailty. There's like a whole bunch of factors that will help us find the treatment combination or modality that's better for you. And so we don't really want the same therapy for everyone.
I have a question about zollitronic acid.
Yes.
Is there a timeline for zollitronic acid in terms of like how long it should be given or intervals?
Yeah, that's a really good question. So the first trials that showed that drugs like zoledronic acid, and some of you from older years would remember pamidronate. Those are drugs that when they were first evaluated were given for 2 years, like monthly for 2 years. And over time and those were the trials that showed better than doing nothing. It helps decrease bone pain, the need like bone fractures and need for radiation and things to bone lesions. However, over time, we recognize now that the zoledronic acid lasts in your bones a long time. You probably are all loaded up after even a few months of it, and it just stays in your bones for years and years. So we probably don't need we probably don't even need 2 years of it. But back when the study said 2 years, it was only because they stopped the study. It's not, and so back when we had trials going 2 years, we just kept going. And there are some people out there who have had years and years of it. And we don't know what the right amount is, but probably shorter these days than what we thought was endless. Mostly because it lasts in the bones a long time. Secondly is it can cause some side effects, right? It can cause some problems with the jaw, particularly if you have tooth problems and you have to have an extraction, the jawbone doesn't heal up well. It's called osteonecrosis of the jaw. It can cause some bone fractures in your pelvis over time. They're called insufficiency fractures just from thinning bones. Like there's lots of things that being on any treatment for many years can cause. So what we generally do these days is we'll use it for 2 years, and sometimes we won't even give it every month. We'll do it every 3 months. There's a study suggesting that's just as good. And then we'll stop for 2 years. And then when the patient has relapsed, and it's only when the disease is active that the bone loss is the most, is most active. So if you're sitting quietly with myeloma, on Revlimid maintenance, you probably are not losing a lot of bone, but it's when your myeloma is really active. So when people relapse, we start it up again. And sometimes we only give it for 6 months, maybe a year, until the myeloma is quiet again, and then we stop. So that's just a bit anecdotal, because there's no trials supporting that approach, except it's just we've learned a lot that you probably don't need that much. Sorry, behind you? Oh, sorry.
Question, you spoke about clinical trials at the beginning. When is an opportune time to consider a clinical trial? Or you just kind of leave that up to your doctor, or is it at relapse, or is it a certain stage of disease? What is that?
Yeah, so we have trials at all stages of disease. And we have trials for someone who's newly diagnosed for their first treatment. Typically, the people who are most interested in trials obviously have had a lot of the standard treatments already and now are looking towards, what else is there besides doing, sometimes it looks like standard options are starting to run low. As I said, when people have had exposure to those 3 main classes of drugs, that's often when we say, let's go down the immune-based therapy. And currently, although cilta-cel is approved, by Health Canada, like in March. It's not funded yet. So all these treatments are only accessible on trial right now, the immune-based therapies. But the key is we have trials at all points. So if you're kind of interested in trials, you should always ask your doctor, and if you're not with one of us at Princess Margaret, ask to refer to us and say, it's not even it needs a referral, but more a question. Your doctor can email us and say, are there any trials for this right now? And we'll say, no, we do, or no, or yes, we do. And if you're interested, we're happy to see you.
So there's a question here. If someone has had very significant allergy reaction to the drugs during the stem cell transplant, referred to as Stevens-Johnson syndrome, are there additional treatments and drugs available to someone who may not then be able to have our regular drugs? Or regular drugs?
Absolutely.
And would that be a case where they would reach out?
Sure. Stevens-Johnson's is I'm just picking that out because that was in the question, but there can be all sorts of types of allergies, but Stevens-Johnson's is a bad skin rash that not often, but if I had to blame a drug, it's mostly with drugs like Revlimid and pomalidomide, these immune modulatory drugs. And yeah, it's problematic if you have, it's really bad skin rash. And so we have different approaches to allergies. If it's to one of those two drugs, we at Princess Margaret have a protocol to desensitize you. It's kind of like the allergists. They give you like a little dose. If you're allergic to nuts, they'll give you a little bit and then just keep giving you more and more until you develop tolerance to it. And the reason why we think that's important to do is because these are pretty critical drugs. There are 3 big families of drugs we use, right? The immune modulating drugs, immunomodulatory IMiDs, that's Revlimid, pomalidomide. The proteasome inhibitors, that's Velcade, carfilzomib, and the monoclonal antibodies, daratumumab, and now there's a new kid on the block called isatuximab. So if you're allergic to one of those classes, it really, binds your hands, and we really don't want to limit your options. So we try to desensitize. There are some allergies, though, you just can't desensitize to. If you have what we call an anaphylactic reaction to something, where you have a major shortness of breath and have to go to the ICU or something, that's not something we would ever chance giving you again. And so there are always alternatives.
Is Shingrix covered in Ontario now?
No, you have to pay for that, unfortunately, insurance or out of pocket.
I was wondering if you can explain why patients become resistant to their chemo drugs. I understand that there are a lot of different kinds of myeloma with mutations, and then the mutation take over and overwhelm after the treatment becomes resistant. What is your explanation on that, please?
So there are 100,000 researchers working on that question right now, because we really need to understand the mechanisms of resistance before we can overcome them. And so every drug has a different mechanism. I'll just give you an example. Like for the BCMA targeted drugs, some very small percentage of patients lose the BCMA because they develop a mutation, and that BCMA is no longer targetable, right? But that's a small percentage. There's lots of other patients that become resistant because they have too many in your, we call it your tumor microenvironment, which is like your bone marrow and your blood system. You have substances that can lead to tumor, I don't even know how to explain it, but it's your T cells can be kind of exhausted. You can have inhibitors that are floating around that inhibit your normal immune function, and those can all play into resistance. So there's many, many different ways that you become resistant to treatment. And we know that at diagnosis, all myeloma patients have multiple clones, like typically 6 or 7 different clones of myeloma, and each clone may have a different pattern of resistance to different drugs, and that's the rationale behind using multiple drugs at once. If you just use one drug and clone number 1 is very sensitive, it's going to go away, but clone number 2 is not very sensitive, then that one's going to just grow, right? So we want to hit as many clones as we can. Why individual clones are resistant is, as I said, we don't always understand. Any other questions? Oh, Dave.
Yes, thank you. You've described research about 3 cellular therapies, and that for us is encouraging.
Those are 3, just so I could correct, 3 immune therapies. Only one of them is cellular. That's CAR T. Just so.
What do you see in the future as other possible immune therapies that may develop and keep us going longer?
Yeah, there's lots of new targets, right? So the most common target for immune-based therapy is BCMA, but there are lots of targets that are being evaluated, not just for CAR T, but for the bispecifics and also the antibody drug conjugates. I didn't talk much about that. Like belantamab, there are different targets, but they also attach different toxins. For CAR T as well, we're starting to develop smarter CAR Ts that target 2 targets at the same time, so that if, let's say, you've got a BCMA target and that BCMA marker becomes weaker for some reason or drops off the surface of the cell, then you've got a second target that's automatically targeted by the CAR T. So there's like smart CAR Ts that are targeting more than one thing, or there are CAR Ts that, because one of the major side effects is related to activating the T cells. So we've got these CAR Ts now where you can genetically engineer them so that if the patient is having too much CRS or some kind of toxicity, you can shut it off, right? Instead of just hoping the patients will get better and supporting them, we can actually use a genetically based built-in shut-off system, and so turn it off. So all sorts of really neat things when it comes to immune-based therapies.
One more.
Oh, okay.
Is there any data on the dose size of Revlimid efficacy on duration of myeloma control or maintenance?
The dose? Yeah. Yeah, that's a good question, because there are studies looking, lots of studies, sorry, not lots of studies, but the dose of any drug when it's in development is based on like pushing it to as high as you can before people can't tolerate, and then just dropping it off a bit. But then lots of people may do well at lower doses. And so we don't really know whether one dose is, we have to push the same dose on everyone. For Revlimid, the treatment dose typically is 25 milligrams. But we also know that it's cleared by the kidneys. So if you have kidney dysfunction, you have to go to a lower dose. So lots of things that make us adjust the dose of Revlimid, but what is the optimal dose? I don't think we know. I think none of us have too many qualms about dropping the dose if we need to for side effects. Like if you're really having problems with your platelets and keeping them up because Revlimid drops your blood counts, we'll drop back. And many patients will continue to do well with a lower dose. So the long answer to that is there's lots of different dosing, and there isn't really any one dose that's being tested that we think is going to turn out to be the best for everyone. Oh, sorry.
I think we could probably go on for a long time. It's a very interesting topic, but we're going to have to start tidying up pretty soon. So I think we have time for 1 or 2 more questions.
So I want to ask about cure. We didn't here. Is there anything you said today that might be something that you think would be a cure? And how would you indicate? What would be?
So, yeah, that's a good question. I think a lot of these immune-based therapies, in combination with our novel therapies, moved earlier. Like you don't wait until someone's failed 3 or 4 treatments and they're quite resistant. Move them up earlier can potentially lead to, and cure is a funny word because sustained MRD negativity can be just as good, right? You can have disease, but it's not doing anything for many years, and that is often what we refer to as a functional cure. Like it's not really saying that we've gotten rid of every bit of tumor in you, but you don't need any treatment for it, so it doesn't matter. So I think that we could get there with some of these treatments if we're just too early in knowing how to combine them right now. So stay tuned, next few years, hopefully.
Patient is on a maintenance treatment in a rural hospital. Is it likely they would get an MRD standard test? Or is that something only at Princess Margaret?
Yeah, unfortunately, MRD testing, even at other academic centers, is not routinely performed. So no, if you're in a rural center, you will not get MRD testing. I mean, I can guarantee you no rural center is doing it. We've only started doing it ourselves in the last couple of years. But we do, we are still kind of learning what to do with it. It's informative in that it tells us the likelihood that you're going to hold your disease longer. But to date, it isn't quite changing our treatment. As I showed you before in that study where 80% of people with high-risk disease can get into MRD negativity. So they then decided they would stop treatment on that study, and it's not held, like they've relapsed. So we're not quite sure what to do with the information. So if you're in a rural area and you can't get MRD testing, don't despair. I mean, it's not changing much just yet. We think it will in the future, at which point I hope we'll be able to roll out MRD testing in more than just Princess Margaret.
I'm not a big fan of
Bone marrows. Nobody is.
So again, Dr. Chen, thank you so much for coming here today. I know putting together the slides, it's a lot of effort and time on your part, and spending your Saturday with us and imparting your vast experience and everything you do for patients, for research. Well, it's all for patients ultimately. So thank you again so very much.